Hello and welcome everyone to the California Opioid Safety Network Accelerator Program's core webinar on strategies for reducing opioid demand. This is the second webinar in our Boots on the Ground series, which focuses on practical strategies for coalitions to reduce demand of opioids in their communities. My name is Amy Max from the Center for Health Leadership and Practice at the Public Health Institute, and I'm very pleased to be welcoming you today. The presentation portion of this webinar will be an hour long, and then we will open the line for conversation with all of you as we build our learning network around opioid safety strategies across the state. Today's session will be recorded and made available to you in our weekly program newsletter and also on our website. You can also find a recording of the last session in this series, which focused on strategies to reduce opioid supply, in the video section of our website. So before we begin, I want to review some housekeeping information. On your screen now is the 866 number for the WebEx assistance line. Please reach out to them if you do have any technical difficulties. Also, feel free to use the question and answer panel as shown on the screen, and for any questions that you might have outside of the live discussion segment. You can type your questions into the panel and direct them to all panelists. And please remember to click send when you enter your message into all panelists. The goal for today's webinar is to introduce you to a series of strategies that your coalition can take to address the demand side of opioid safety. We will be providing a high-level overview as part of this core webinar. And in phase 2 of the Accelerator program, which begins in July, we will start a series of web-based discussions and calls with subject matter experts, where you'll be able to take a deeper dive into some of these strategies, talk about challenges, and exchange ideas with other coalitions. So the desired outcomes for today's webinar are that you'll understand the drivers of demand for opioids of abuse in your community, be able to describe potential strategies that coalitions can implement to reduce the demand for opioids, receive some practical suggestions for implementing strategies based on the experience of other coalitions, and understand the range of available tools and resources that will make available to you to implement strategies. Our agenda for today is to go through in the presentation a description of the opioid demand problem, describe a list of practical strategies you can take with your coalition. We'll have some guest speakers provide some lessons from the field, and then review some available tools and resources. And at the end of the presentation portion, we'll open the lines for some discussion and Q&A. For those of you who are joining one of our webinars for the first time, our team at the Center for Health Leadership and Practice at the Public Health Institute manages the California Opioid Safety Network in partnership with the California Healthcare Foundation and our partners at the AmeriCorps Vista program. Our Accelerator program focuses on supporting local coalitions across these 5 key areas. And today we're focusing on the opioid safety strategy piece, which is highlighted in yellow. So before we begin, we just want to go through an initial poll question for all of you on the line to get a sense of which strategies that we'll be covering today that you're already working on. You'll see a poll question pop up on the right side of your screen, and please mark all that apply. The question is, what strategies your coalition is currently pursuing to reduce the local demand for opioids? A is community-based primary prevention of addiction. B, safe prescribing and supporting tapering from high doses. C, healthy pain management and promoting alternatives to opioids. D, initiatives to reduce stigma of opioid use disorder. E, expanding local referral networks to MAT providers. And F, expanding the number of MAT providers. So please take some time to fill out the poll and click all that apply in terms of which strategies your coalition is already working on. And so now I'd like to introduce our presenter for today, Dr. Matt Willis. As many of you know, Dr. Willis serves as our clinical lead for the California Opioid Safety Network. He's the health officer in Marin County, where he helps lead the RX Safe Marin Coalition, and has really been a true leader in supporting partners across the state in advancing opioid safety efforts. So take it away, Matt.
Thank you, Amy. Do I have control?
Nice.
I don't have control yet.
Oh, it might be delayed.
Okay. Well, there we go. Hi, everyone. It's great to be here with you today. So this is the second of these three first installments of the Boots on the Ground webinar series, as Amy mentioned. Our vision is zero opioid overdoses. And to get there, we know that we need to be addressing simultaneously the problems of supply and availability, high opioid demand, and take new steps to prevent overdoses in real time. Of course, there'll be multiple strategies in each of these areas, and we'll be focusing on sort of offering you a menu of options from which to choose deeper dives when you get into implementation of any one of these potential strategies. So here we are today on reducing demand. Why is it important to reduce the demand of opioids? This is the latest data that's come out of the CDC and offered some somewhat discouraging news around the acceleration of the opioid epidemic nationally. 2016 saw the greatest rise in opioid overdose deaths of any year that had preceded it, despite the efforts that really started accelerating themselves around 2013 against this issue. The primary contributor, if you look at this graph more carefully, to that green line, which is the top line of all overdose deaths, is the orange line, which is other synthetic opioids, particularly fentanyl. Fentanyl has accelerated significantly, especially in the East Coast. In California, it represents only about 12% of our total overdose deaths, but in places like Ohio and back east, it can be up to 3/4 of the opioid overdose deaths. So the epidemic is gaining in scope, but also in complexity. To understand the context and framing for addressing demand, it's important to just revisit that question of how we got here. This is the way that Kelly Pfeiffer at the California Healthcare Foundation has been framing this. First is the problem of overprescribing. We addressed this in our last Boots on the Ground webinar around reducing supply, and this has been highlighted recently in some of your counties and many California counties who have entered into litigation against opioid manufacturers for helping contribute to this problem of overprescribing. Second, this has been called an epidemic of despair, which is described nicely in Stan Quinones' book Dreamland, where the problems of increasing economic disparities and unemployment, low income, and low educational attainment are very tightly tied to opioid overdose abuse and overdose risk and incidence of abuse. Globalization and e-commerce is another important trend that's fueling this. Heroin and fentanyl are on the rise. Fentanyl is difficult to control because it's coming in through the dark web. It can be obtained through the internet, and obviously manufacturing in China and Mexico has made the supply side even more complex to try and control. And then finally, on top of that, we really don't still have the infrastructure necessary to address all of those individuals who are struggling with opioid dependence and addiction. This is a slide from, on the lower right-hand side here, from 2014. It shows that, a huge swath of our state had 0 licensed narcotic treatment providers or programs. And embarrassingly, many of those correspond to the areas that were actually most impacted and had the highest overdose deaths. And this is one of the most important strategies that we'll be trying to advance with you is to close that gap. The CDC has been starting to talk about phases of the opioid epidemic, and I think it's helpful for us as coalitions to start thinking about framing our work this way as well. We know that, and it was addressed a lot on the last webinar, from 1996 to about 2012, this was really primarily a problem of prescription opioids through ever-increasing opioid prescribing rates and a corresponding increase in people with dependence and addiction. Phase 2 began in 2012, where we started seeing more heroin incidents, and you can see that on the overdose death trends. And then Phase 3 is very recent. Around 2016, we started seeing rapid acceleration in fentanyl. That's something that hasn't been as acute for us here in California, but in some ways we should be bracing ourselves in that there's rapid increases elsewhere. So controlling the supply side with increasing availability of fentanyl and illicit opioids is even more challenging perhaps than the work we've been doing to control the prescription opioids. And so in order to save lives, we need to address demand. This is just to remind everyone, we're on the opioid dashboard. We're seeking to be data-driven and evidence-based in our approaches, both to inform our strategies and to monitor our progress. And to plug every chance I get, the use of the California opioid dashboard, one of the indicators on the dashboard that's helpful to your efforts in terms of evaluating progress relative to MAT is the buprenorphine prescribing rates that are available to all counties down to the zip code level, as shown here. And encouragingly, we're seeing steady progress in most areas there and across the state as a whole. And then another important indicator that has been added to the dashboard is fentanyl. We don't have, because fentanyl, when it's used in the community, is primarily illicit, it doesn't appear in our cures database, so it's difficult to track the supply of fentanyl. But you can see the impact of fentanyl in the new functionality on the dashboard of fentanyl-related overdoses for your community. Finally, in terms of measuring the burden in your community, the Urban Institute recently developed a set of fact sheets for each county that offers an estimate of the number of individuals within your county who are suffering from opioid use disorder, A, and B, the proportion of those who are actually tied into treatment, and offers a numerical estimate of the number of people who do not have access to treatment for opioid use disorder who should. And across the state, they estimate that there's about 2 million people in 2016 who misused opioids. About 1/5 of those, about 250,000, had opioid use disorder, and about 200,000 of those do not have access to medication-assisted treatment. So there's I think a convenient talking point for you in terms of your own advocacy at the local level to look at this Urban Institute fact sheet and get a sense of the numbers within your community that you're trying to address, because they're it suggests that we need more than tinkering on the margins of the existing systems, but categorical change in the way we're approaching this problem, which is why the coalition approach is so necessary. We're trying to open the conversation to include some upstream as well as some downstream strategies here. So the first, getting into the strategies themselves, the first is to prevent addiction. Obviously, we want to acknowledge that the most sustainable method here would be actually preventing occurrence of addiction and dependence itself. We spent a lot of time on that in the last webinar when we discussed limiting supply, and I won't go into that again, safe prescribing being the most important of those strategies. Another important method for preventing addiction are some of the community-based policy systems and environment work that are happening through substance use coalitions that are present in many counties, where they're looking at upstream prevention efforts through focusing primarily on youth and changing community norms. This is a study that was just published in the American Journal of Public Health that showed that there were long-term benefits of an evidence-based model that CDC is promoting called Communities That Care in reducing incidence of and increasing sustained abstinence from gateway drugs among youth by 49% in a randomized case control methodology at the community level over many years, comparing communities that had adopted this model versus communities like and paired communities that had not. So there's an opportunity there that we can get into on future webinars for engaging with some of your substance use coalitions that are engaging in these upstream activities. Another prevention addiction activity is, basic public education that many of the coalitions have engaged in. Some of the methods there include developing simple communication tools that IE Communications and our partners here at the Public Health Institute will be helping share on future webinars in terms of how to best communicate to the public. These are examples here of some of the materials that RX Safe Marin has developed for our public-facing campaign. Many of these are posted in clinics throughout the county and have been effective in sort of changing community norms and stimulating new conversations. Social media is another way to reach the population as a whole, again recognizing that we need to be not only changing our healthcare practices, but making this a community, essentially a social movement of new understanding around opioids. Another important tool, I think, for changing the community conversation is the data that's available to most counties in their describing the burden within their youth. This is the California Healthy Kids Survey that we've used within Marin to say that one in 5 of our young people have used painkillers recreationally, and that in itself really sort of stimulated a lot of local concern. The next strategy to acknowledge is reducing stigma. Stigma itself is one of the drivers of perpetuating the epidemic, and that it is its direct effect on individuals who are suffering from opioid use disorder as shame and not asserting their right to treatment, and maybe not talking about their issue or seeking care. And then also, as we all, I'm sure, experience in this space as coalitions, the either explicit or implicit resistance to participation in these efforts among our partners, whether they are within healthcare or law enforcement or other sectors, partly because of the stigma of the issue that we're trying to address. One of the ways of reducing stigma is having, basically local faces and local stories be part of the strategy. So we want to make sure that our local, the communities themselves are understanding the burden within their own context, and that voices from within that community who may be suffering from addiction are able to share that story in ways that make it clear that it's part of the fabric of our own communities. Another important strategy for reducing stigma, and these are slides from Kelly Pfeiffer of the California Healthcare Foundation, is comparison to other conditions, other chronic conditions, which are much less stigmatized. And there'll be future webinars again on how to reduce stigma. This is one, I think, effective communication tool that Kelly has been promoting in her talks across the state. We're comparing addiction to diabetes, and making the comparison that if we have diabetic patients who fall off the wagon because they have a Krispy Kreme, eat 3 Krispy Kreme donuts. It's a conversation. We might say that they're, I sort of invite some dialogue into how that might have happened and what we might do differently the next time, but there's no suspension of any other form of support for that person based on that. Whereas with someone with addiction, when their chronic disease manifests again, or when they have a recurrence, they potentially lose access to treatment itself, lose custody of their children, lose their freedom if they're on probation, their housing, family, their employment, and in fact their identity, especially if they're tied into a 12-step type program where sobriety is so valued. So we have a lot of work to do in terms of framing addiction as a chronic disease, which are words we use now, but our systems don't reflect that understanding. Next, another important driver of demand is the way in which pain is treated with opioids, especially the use of high-dose opioids for the management of chronic pain. It's important to recognize that patients who are taking more than 100 morphine equivalents per day have a almost 10 times higher rate of death, 120 morphine equivalents per day compared to patients taking lower doses. On the left there, that graph basically shows the risk of death depending on the dose of opioids on a daily basis. And what it shows also is that it really begins at 0 and is linear, but jumps up significantly after about 100. We've made a lot of progress across the state, and most counties are seeing progress in this, partly because of this recognition of the mortality risk for high-dose opioids. But we still need to make sure that we're tapering people safely off of those very high doses rather than cutting them off completely. The CDC has started endorsing non-opioid methods for the management of pain, and there are resources available at the CDC. On this infographic, they say that 1 in 4 people who receiving prescription opioids for chronic pain in primary care actually are struggling with addiction, and that non-opioids like NSAIDs, Tylenol, antidepressants, and anticonvulsants can often be just as effective, as well as non-pharmacologic methods like physical therapy, exercise, and cognitive behavioral therapy. And this is a discrete set of activities around promoting healthy pain management that is an important and emerging area for coalitions to adopt. In Marin County, we did a survey just to determine what the appetite locally was for understanding non-opioid methods, and we found that both among our community members and among our providers, there was a lot of interest in promoting non-opioid alternatives. And based on that, we had a community-wide forum last month that was dedicated to healthy pain management. We're going to spend the rest of the time talking about medication-assisted treatment and reducing demand through increasing access to treatment for opioid addiction. I'm going to start off with a poll question. So what do you see as a primary barrier to increasing access to treatment for opioid use disorder in your community? And they all seem important, so we can prioritize and pick the top 3. The first would be failure to recognize opioid use disorder clinically. In other words, are people coming in and not actually being recognized and identified who have the disorder? That there be too few partners or locations engaged in identification and referral. 3, lack of clear referral processes to treatment providers. D, too few MAT providers. E, stigma of opioid use disorder leading patients to avoid care. F, stigma leading to providers to avoid treating. Next, MAT is undercompensated or unsupported. And obviously some of those are overlapping. And then if you have others, you can put them in the Q&A box. And are we going to see the results of the survey? Okay. We'll give you a little time to...
It's closed.
Oh, it's closed already? Wow, okay, so too few MAT providers was the most common response. Well, you can see from those questions that we're trying to describe in the sequence of MAT provision what are the specific barriers across the systems in which we work. So getting into MAT, one of the most important factors that is really being clear that medication-assisted treatment for opioid use disorder works. It is a safe and effective remedy, and in fact, it is the main remedy for that problem. That, partly fueled by stigma, remains in some people's mind, I think, not as clear as it should be. When we look at studies of SSRIs for depression, for example, we see much lower success rates than we do for medications for opioid use disorder. And most people don't question the efficacy of SSRIs for someone who's struggling with depression, but in fact, this is a much better success rate. This was put together by California Healthcare Foundation, basically looking across almost a meta-analysis of looking across a variety of studies to show that methadone, buprenorphine, naltrexone are all much more successful as strategies for addressing opioid addiction than treatment without medications. Again, so we want to make sure that because the supply side of the issue is getting more complex with greater availability of fentanyl and other volatile and high-potent opioids, we need to make sure that it's easier for people to access MAT than illicit opioids for people with addiction. This is just a bit of hope before we get into some of the strategies, is to see, look what happened in France in the 1990s. They were seeing increases in heroin overdose deaths up until about 1994, and buprenorphine was really not widely used at all. And starting in 1996, they basically changed the game completely around buprenorphine by making it much more easy to prescribe and access. There was no special waiver process. It was not a segmented and separate activity. Addiction treatment was actually integrated much more into primary care. Buprenorphine was essentially normalized in some ways, and the prescriptions of buprenorphine increased dramatically over a short period of time with a corresponding decrease in heroin overdose deaths. So that's the kind of, massive, I think, social and clinical change we need to be looking for in our approach to medication-assisted treatment, especially if we recognize that we have 200,000 people, if the Urban Institute report is correct, who need access to MAT who currently don't have it. A little back of the napkin math would suggest that even if we do 100 more people per week in the state of California for accessing MAT to close that treatment gap, it would be, I think my math is 40 years before that 200,000 people would, before that gap would close. So something dramatic. We need sweeping change. One important way to think about this and organize our thoughts around connecting people to addiction treatment is to recognize the sequence for an individual who has moved from addiction into treatment. What were the necessary steps for that to occur? And they're drawn out here. And it's important to see that if any one of these things is not in place, that individual with opioid use disorder will not actually get into treatment. So all of these things need to occur in every community for us to close the treatment gap. So on the far left, we have opioid use disorder develops and an addiction develops. We need to recognize that when first was a failure to prevent that from occurring, and that person is at risk for overdose. The next thing that has to occur is that individual needs to be recognized as such, as someone with opioid use disorder, which can happen ideally in a clinical setting or someone else in the community who is empowered to see the signs and recognize the signs and offer treatment or a referral, or that the patient themselves are aware and they seek help. Second, that the treatment be offered and accepted by the patient. So the provider has to be empowered to act upon that knowledge if they do screen someone as positive. They can either initiate treatment or refer, and the client is able to access and accept care. Third, that the referral actually is successful. So the linkage is in place to the treatment option. The reason we pulled this out as a separate strategy instead of activities is we know how often that is, in fact, the rate-limiting factor. It's almost, in many cases, it's a logistical or operational issue, but does represent a significant barrier to people getting tied into treatment successfully. And then finally, that the treatment itself begins, that there's sufficient local treatment capacity, there's enough X-waivered prescribers, and that and recognizing that people may relapse, fall out of treatment, and need to have that system perhaps reinitiated for them all the way through. Many of our strategic efforts focus on the last of these pieces and think that, just having more X-waivered physicians is the answer. And it's certainly one of the major limiting factors as reflected in your survey, but it's important to also recognize the other elements of the system that contribute to this. So to summarize that, we need to be identifying patients, we need to be referring them, and we need to be treating them. And those will be expanded upon by the speakers that we've invited to join us today. This is one prompt for thinking about that first piece of expanding, where we can identify patients. And it's a suggestion that we begin to map out the touch points within our communities where people with opioid use disorder are actually touching the system, which includes our first responders, our primary care clinics, et cetera. This is a graphic that has been used for just talking about the coalition network and explaining what a local coalition is and who the players are, it actually also offers a really convenient suggestion of who the partners might be in your community where patients with opioid use disorder may be touching the system, an invitation to those partners to actually engage in more aggressive screening of opioid use disorder and referral, mental health and addiction treatment services, first responders, health plans and medical societies, pharmacies, law enforcement, jails and corrections, school and academic institutions. I'm just making my way around the circle here, public health, healthcare providers, hospitals, and clinics. So all of those are potentially partners in expanding our screening process across the community for identifying individuals. And I'm sure that in your community, as it was in ours, that those relationships may not be yet optimized. In Marin County, we just started a process where we're using our first responders, our EMS system, and looking at EMS 911 records to look at opioid overdose events and reaching back to survivors of those events to try and tie them into treatment with Bright Heart Health. And Dr. Khan, who's joined us on this call, will be able to speak to Bright Heart's process there. It's just an example of how a new partnership has actually increased our throughput into our medication-assisted treatment system. The next strategy is optimizing linkages to medication-assisted treatment. I'm not going to discuss that because that will be discussed by our speakers who will discuss the SafeMed LA example. Dr. Brian Hurley will speak on that, and Dr. David Kahn will explain Bright Heart Health's approach to strengthening linkages to treatment and offering treatment. Many of you are aware of the hub and spoke model. This is a federally endorsed and supported strategy to address that continuum of need across the system for tying people into medication-assisted treatment. And we'll hear more about that from Brian. And the final strategy to reduce demand that we'll be addressing on the call is increasing treatment capacity, and I know everyone's very interested in that. One of the simplest methods is simply offering training for providers locally to obtain their X waivers. This is something that many coalitions have subject matter experts in their communities that can actually hold the trainings. The half and half, which is 4 hours of on-site and then 4 hours of internet training, seems to be one of the most painless and most efficient ways of helping our providers obtain the X waiver. We want to make sure that we're not overly optimistic in terms of our assumption that an X waiver provider will actually begin prescribing. When we look at our numbers, we see that there are actually many X waiver providers who are not empowered to actually provide service for buprenorphine, partly because they don't have this local system support in place that will be addressed by our speakers. So we're going to start with introducing Dr. David Kahn. Dr. Kahn is the Medical Director of Bright Heart Health and President of the California Society of Addiction Medicine. He's a clinical faculty member with UCSF, and he's a psychiatrist certified in addiction medicine. I got to know Dr. Kahn partly through our new relationship with Bright Heart Health in Marin County, working with us to work with our emergency departments and our emergency medical service providers to link patients who have been identified as having opioid use disorder or other substance use addiction issues from within those settings. And it's been a real game changer for us, and I know David's been working with other counties, and we'll talk more about that effort. David?
Thank you so much, Matt. Can you hear me okay?
Yes, we can.
Okay. Once again, David Kahn. I'm a psychiatrist by training, board certified in addiction medicine, and I wanted to talk today for a few minutes about what we've learned from the field around doing telemedicine for medication-assisted treatment. Bright Heart Health, this is sort of taken from our splash screen, but this is what treatment looks like over the internet. You'll notice if you have any internet-enabled device, you can access treatment. If we think about telemedicine, it's ready and available. There have actually been studies looking at telemedicine and in-person treatment for opioid use disorder, and it turns out that the outcomes are generally same or similar, sometimes slightly favoring telemedicine. But the patient satisfaction is dramatically improved. If we look at the numbers, there are about 350,000 telemedicine patients who access telemedicine in 2013. That number is anticipated to be 7 million for all types of telemedicine. And as I mentioned, that the outcomes were just as good or better via telehealth. And if we think about the number of mobile devices, there's far more of those than there are hospital beds in the United States. So telemedicine really is poised to explode at this point in time. Some of the keys to telemedicine, if I were to say how you conceptualize Bright Heart Health, think of us as a full-service addiction treatment program which embraces everything from harm reduction and engagement all the way to the full scale of services without physical walls, meaning that people can access it through their internet-enabled devices. We try to work, we have many different places in which we work. We work with identification. We really want no wrong door. And of course, we find that there's doors that people didn't anticipate. Matt, I think that those comments that you talked about in the different inputs into treatment, I'm pleased to say that we've engaged, not quite all of them, but many of those things with Bright Heart Health. To refer patients to Bright Heart Health, you can either go to the website, email, we have a secure texting option, and our treatment includes MAT. And by medications, we're talking about buprenorphine primarily, but we also use naltrexone where indicated. We also have care management, counseling, individual as well as group, and we have the full spectrum of services from engagement all the way up to intensive outpatient programs. We've got a significant capacity, and I'll mention the many partnerships that we have. One of the things that we have is an app. So there's a Bright Heart Health app. It's available in the Android store, soon to be published on the iPhone store. But this is what it looks like when you open up our app. You can connect directly to video appointments. There is symptomology tracking. And one of the nice things about being quote-unquote digitally native is anything that happens we can really capture. People can attend support groups and help with their referrals management all through the app. One of the things I'm most proud about with Bright Heart Health is that we take a community health approach, meaning that we recognize that there's many inputs into the system. And if we do the outreach across the system, we're more likely to catch people at varying points of readiness to change. All of these things are the same things that Matt covered in his prior slides. But whether it's ED hospitals, behavioral health, drug courts, corrections, these are all doors in which you can get into care with Bright Heart. Now, I wanted to sort of drill down to a specific example. If you look at emergency departments, there are 130 people who are abused or dependent, but when we go up there, we see 32 emergency department visits within a year. And then 10 of those treatment admissions are for misuse of substances, and then there's one death contained in between. So we don't want to get to the point of death, but there's many opportunities to intervene. We know the number of people out there, and the emergency department turns out to be a prime location to interact with patients. When we interact with emergency departments, we can either do telemedicine directly in the emergency department or the clinic. We are one of the hub and spoke system recipients for California, and if your local coalition is interested in partnering with us, we can definitely do that. And moreover, we can get you that technology. Tablets are cheap. We can get you a tablet. We have the technology budget for that. So with the emergency department, whether somebody can get an expert intervention, which we can do. So we have tablets deposited within emergency departments where we can do direct contact with patients. And as a program, we're open 24 hours a day, 7 days a week with live call support. The second option would be to do a referral, and then we can get that appointment within 24 hours. This is a list of some of the emergency departments that we have relationships with. Notice it's California as well as Ohio. Ohio is another state that we received the grant. So I wanted to go through a case study, and this is through the Community Hospital of the Monterey Peninsula. I know Casey Grover, one of the emergency physicians, is on the line, but can't talk until afterwards. But what we did with CHOMP was that CHOMP was an interesting setup. For a long time, they actually had somebody in the community who could accept Medi-Cal referrals and commercial referrals, and so they were starting patients on buprenorphine and connecting them with ongoing treatment. And unfortunately, they lost their provider, and to the quasi-emergency physicians, they didn't feel like he was responsible to do wallet biopsies to see what their insurance is before deciding whether to put somebody in treatment or not. And so they had to go back to the old system, which was giving clonidine, helping patients to do medically supervised withdrawal, but they couldn't get them connected with the treatment. I met Rev Close, who is another physician over at CHOMP about a little over a year ago, and we talked about implementing our services with CHOMP. And the results were that we were able to implement connections with CHOMP within less than 30 days. We trained the ED staff, we distributed handouts, put posters out there to let people know about our services, and to date we've had more than 25 intervention and referrals. Remarkably, 100% of the patients from the point of getting buprenorphine in the ED with either Dr. Close or Dr. Grover made their first appointment. And if we look at our retention rates at 30 days, we had an excess of 95% retention, which was a significant improvement on the Yale study, which showed that if you give somebody a single dose of buprenorphine, you get somewhere above 70% retention. So we did better than that. And so this is a very practical example of how we were able to deploy into an emergency department a hotspot of sorts and connect people to the seamless continuum of care. And so with that, I'll stop. One thing I'll say about Bright Heart Health is that we accept all forms of insurance, Medicaid, Medicare, most forms of commercial insurance. And really the key to what it is that we're doing is to say that motivation should really be the only barrier. So with that, I'll hand it off. Thank you.
Thank you so much, David. We'll have an opportunity for questions and answers at the end. I want to be clear that, for the purposes of this webinar on reducing demand, we recognize that telehealth is a really emerging and important tool for us, and that Bright Heart Health is among a number of telehealth options. It is emerging Bright Heart as one of the leaders in this space, but just want to be clear, we're not officially endorsing any one product, and there are others out there, but we're thrilled with the progress that Bright Heart has made, and it's been an effective partnership for many of us. Next, I'd like to introduce Brian Hurley. Brian is an addiction psychiatrist and medical director of the Co-Occurring Disorder Services at Los Angeles County Department of Mental Health. He co-chairs with Gary Tsai the Medication for Addiction Treatment Action Team at the SafeMed LA Safety Coalition, where he advances organizational capacity in LA for substance use disorder treatment for people with co-occurring mental health and substance use disorders. And that's 10 million people population, so that's a big job. He also informs strategy for the American Society of Addiction Medicine, California Healthcare Foundation, California Primary Care Association, and the American Academy of Addiction Psychiatry. Brian will be talking to us about the work that he's been doing through the SafeMed LA Opioid Safety Coalition to increase access to MAT in their clinics. Thank you, Brian.
Good afternoon, everybody. Thanks for having me. So as was mentioned, I co-chair the Medications for Addiction Treatment Action Team. It's one of actually a number of the action teams in SafeMed LA, which is LA County's local coalition. And I should just mention here, the term that people use a lot is medication-assisted treatment. I actually have been promoting the use of medications for addiction treatment because, just as was mentioned, medications are part of the treatment. They are not necessarily separate from, or they're not necessarily assisting anything beyond, their medication effects. And the vision for the way that we're planning to do medications for addiction treatment in LA is really expand the capacity to provide medications for addiction treatment at all health sites. So by all health sites, I mean community health centers, hospitals, emergency rooms, community mental health centers, correctional health services, be able to link people from field-based services to treatment providers that offer medications for addiction treatment. But that's the idea. And so the conceptual framework is actually really relatively simple: to get clinicians ready to prescribe, patients willing to participate, and organizations that are willing to, or not willing, but capable of actually delivering these services. That's how you get to treatment. And there's a pretty good study that was published last year out of Venice Family Clinic, which is one of the federally qualified community health centers in Venice, California, in our county. And what Kate Watkins, who was the primary investigator on the study, and this is, I should be very clear, this is her slide, not my slide, but when she goes and talks about the study, she says, you know, it takes a lot more than training to actually develop a system that delivers evidence-based treatments. So certainly, supportive and knowledgeable leadership and staff is critical, and training is important for that. She also identified that having technical assistance and experts available for consultation, treatment protocols, parameters, those things create the context where, say, an X-waiver prescriber is going to actually then use that X-waiver to offer buprenorphine. That's also, treatment protocols are where patients who might be coming out of, say, a correctional setting or a hospital setting who would be potentially appropriate for naltrexone long-acting injection for opioid use disorder, those are having treatment protocols where you can link somebody to ongoing naltrexone long-acting injection is also important. Then, of course, delivery system redesign. At Venice Family Clinic, they created a new care coordinator position really just to attend to all elements of the workflow at their own community health center. We're working within our county on developing sort of a master workflow through all of the health systems, but as you can imagine, with 11 million people in the county and hundreds and hundreds and hundreds of agencies, there's a challenge to having one workflow work across the board. She also found that patient self-management materials and linkage to community resources and a registry was also really relevant to getting an organization to really embrace the delivery of medications for addiction treatment. And there's actually a literature on this. There was an article published in Current Psychiatry Reports that said, look, there's lots of barriers to medications for addiction treatment. Many of them are government and insurance policies, and I have to give credit to Dr. Khan and the California Society of Addiction Medicine for really pushing the state to include, access to buprenorphine on the Medi-Cal formulary. One of the things that I helped participate in was getting naltrexone long-acting injection approved on the Medi-Cal formulary as a pharmacy benefit. I mean, you have to be able to address those government insurance and payer policies in order to be able to actually, advance medications for addiction treatment. And then there's all these like logistic issues that need to be addressed, like have you identified which pharmacy is, going to take care of your patients? That is, pharmacies that either are contracted with the Medi-Cal payer in your community. In LA County, I work for a county system that sees a number of people who are not and will not be Medi-Cal eligible. And those people are covered by a county-run program called My Health LA. So one of the things we had to do in LA was address, do we have coverage for buprenorphine and access to other forms of medications for addiction treatment on the My Health LA formulary. And then for those programs, the equipment, let's say the fridge to store naltrexone long-acting injection, if that's something that you're using, or, if you're dispensing, do you have a system for dispensing? I mean, those sorts of things need to be addressed. So there's system-level barriers. And then there's provider-level barriers, and honestly, one of the areas that most kind of implementation science focuses on the system and provider-level barriers, but our patients carry a whole number of attitudes around thinking about medications for addiction treatment. So we build systems that segregate physical health from mental health from substance use disorder treatment. And so patients tend to think, oh, I'm going to go to my primary care doctor, which is going to help, that person's going to help me with my hypertension or diabetes or my asthma, but they're not going to be able to help me with my opioid use disorder. Not because they can't, but because the patient has that in their mind that in a system that segregates these services, you don't necessarily go to your community health center for substance use disorder services. And so there's a number of patient-level kind of providers, concerns, attitudes, and frankly, informational deficits that are also important to be addressed. So training is necessary but not sufficient generally to change provider behavior. And so one framework that we've been working with in the county is to think through what are our systemic facilitators, how do we build organizational capacity and provider readiness to affect the supply of medications for addiction treatment, and then working with our community advocacy groups in order to think through how are we going to offer services in a way that are going to be accessible to the community. There's actually a document I just want to promote, and it's the ARC medication, in this case they called it Medication Assisted Treatment Models for Care for Opioid Use Disorder in Primary Care Settings. There's a whole number of features for what are common success factors for the delivery of opiate use disorder care in primary care that are articulated in this document that has been really helpful for us here in LA County. So I'm not going to describe everything in the county to you, but in LA County, there's the LA County Board of Supervisors created something called the LA County Health Agency that is supposed to link our 3 different departments. We have the Department of Health Services, which supports our county-operated hospitals and clinics that attend to people's physical health. We have an LA County Department of Mental Health, which addresses every mental health condition in the DSM other than substance use disorders. And then our specialty substance use disorder treatment is managed by yet another county department, the County Department of Public Health. So in our county, we have tremendous silo issues in the extent that you have different people regulating, funding, and managing care in the physical health, mental health, and substance use disorder treatment sector. Recognizing this, the LA County Board of Supervisors actually directed not just the county health agency, but really the whole body of county departments to create an initiative that was initially called You Can Conquer Addiction Now, but that was a term we didn't like, so we renamed it to the HEART Collaborative, Help for Addiction Recovery and Treatment. That has become a collaborative between the LA County Sheriff's Department, Fire Department, our coroner and medical examiner, our district attorney, and then through the 3 health departments through the county health agency. And it has been actually tremendously helpful because we're able to talk to the coroner about what are you seeing regarding fentanyl. And we were able to learn that the tests that they use for fentanyl changed and their protocol changed in May of 2016. And that's helped us think through the data we're seeing from the coroner and the geographic information of who is dying from opiate overdose and where, to then think through, okay, well, where should LA City Fire potentially intensify its field-based services? We were able to get naloxone in the hands of all of our sheriff's deputies that are out in the field. We're working with the district attorney about thinking about a rational way of connecting people when they're being charged for drug-related offenses, of connecting people to treatment, and then, of course, wanting to build capacity for medications for addiction treatment in any health-facing department. So our systemic facilitators and the things our Medications for Addiction Treatment Action Team has been really focused on is making sure that all of our county departments have formularies that include all of the medications for addiction treatment when appropriate, that we develop standardized practice documents and that we distribute those policies, practices, and procedures. But probably the biggest area of work in our Medications for Addiction Treatment Action Team has been expanding provider readiness. So we run buprenorphine waiver trainings several times a month. We do trainings on naltrexone long-acting injection. We have trainings on naloxone, which are run by our kind of sister action team, the naloxone action team. We have medications for addiction treatment resource repositories, and there's a whole number of them from the California Healthcare Foundation's Treating Addiction in the Primary Care Safety Net, or CAPSI program. We run internal learning collaboratives where we meet every other month to talk about local barriers and how to overcome them. We offer some limited decision support and technical assistance, and then support people getting linked to programs like the AAAP STAR TA program, the California Healthcare Foundation, and oh gosh, I think it was the Institute for Clinical Improvement, their own TA program. The California Primary Care Association is running a technical assistance program. So we try to link people to the available decision support and technical assistance programs to try to create the context where providers are really going to be able to offer medications for addiction treatment. I should mention that The drug Medi-Cal waiver, the 1115 waiver in our state in LA County was operationalized to create a 24-hour phone line. So anybody can call 24 hours, 7 days a week to get linked to our specialty sector. This is not run through our MAD action team exactly. It's run by the County Department of Public Health. But there's a 24/7 access line to accessing specialty substance use disorder treatment, which is not specific to medications for addiction treatment, but you can click on, if you want to look for just opiate treatment programs or just programs that are capable of using medications for addiction treatment, you can use we have a filter bar. And you can also segment by population. So I want a male bed or a bed for somebody who identifies as LGBT or so forth. This tool can help you with that. And it's a publicly available website. So we have the service and bed availability tool that anybody could go on and look at the treatment options that are available here in Los Angeles. The Department of Public Health also created this Medications for Addiction Treatment Resource Library in partnership with UCLA that includes a whole number of really practical, what's the protocol you use, or what's the, the consent form you use, or what's your process for toxicology. But there's this whole list of resources and geared towards providers, geared towards patients. And it's, again, publicly available. We offer through something called eConsult, an addiction medicine eConsult portal, where people can get expert consultation on medications for addiction treatment. And this is our sort of local version that's supposed to serve a similar need to what the UCSF Warren line does. And anybody can reach out to an addiction medicine specialist and get consultation about the use of medications for addiction treatment. And then I should also mention, there's 17,000 people that rest their heads in the LA County Jail at any given time. We finally got buprenorphine on the formulary and are busily working as part of a newly created addiction medicine service to actually make medications for addiction treatment available to the really huge numbers of people with alcohol, opioid, and tobacco use disorders that come through the Twin Towers, or this is the Men's Central Jail. There's actually 4 jail facilities in LA, but come through one of those correctional health facilities. And I'm certainly happy to answer more questions, but I think I've exceeded the time allotted. So thank you so much for your time and attention, and I will turn it back, I think, to you, Dr. Willis.
Great, thank you. Well, that's an impressive array of services, and really, I think, highlights the way that we try and encompass, increased identification of individuals, robust referral processes, and clear lines of communication and transfer of care, and increasing the overall capacity in terms of offering treatment that's going to be necessary, and hopefully can be replicated across the state. I'm sure there are some people who are from smaller jurisdictions that hear that list of things that you're able to do and wonder how they might be able to accomplish something like that in their own county. And I think we will be working with every coalition to sort of determine what are the highest yield subset of activities that might be feasible in any area and one that may be less resourced. And really leaning into those great resources that you and your team have been able to develop. To that end, I just want to call out, I actually have a little more. So we're not quite to the question and answers yet. I'm going to discuss some of the tools and resources that we're going to be making available to all of the coalitions through the website here. We will offer that, which you just mentioned, what Brian mentioned, the SafeMed LA MAT reference library. We will add the AHRQ MAT models for primary care settings that Brian referenced. The SafeMed LA client referral tool, just as an example of a process that can link patients from identification into treatment. The CDC opioid, non-opioid pain management recommendations and infographics that I shared are RxSafe Marin public awareness of opioid risk materials, just as examples, and these can be offered without logos, so people can offer that, just add their own logos to them and make them their own. The Urban Institute California Opioid Treatment Gap Report is something that should be familiar to you, and if not, certainly something that you should look up. You can even Google it, and it's an easy drop down to pick your county and see what your local numbers are. And then obviously Bright Heart Health is now a resource for us in terms of helping us understand the opportunities for tele-MAT. Are there any other resources that? And we'll continue to. If anyone has any other heard of anything in this call or has other suggestions for resources that we would make available, we will. And there's a portal for that for the COSN network. I'm going to end with, before we open it up for question and answers, just this, inspiration that we can look back to in our own nation in 1995. The AIDS epidemic was the defining health crisis of that time, just as the opioid epidemic is now. In 1995, there was 50,000 deaths to AIDS. We had 42,000 opioid-related deaths last year, which is 5 every hour. So in the last hour that we've been having these conversations, at least 5 people have died from the opioid epidemic in the U.S., which is sobering to think about. And if we think about what changed to help us get in front of the AIDS epidemic, a lot of those strategies apply to what we're dealing with here with opioids. Remember that kids with AIDS were barred from schools, and misunderstanding about AIDS left a lot of people ostracized and alone. Then a couple things changed. We got wide availability of effective medications and a broad anti-stigma campaign. Rock Hudson, Magic Johnson came forward to see AIDS as a disease and not as a character flaw or a moral issue. And we made antiretrovirals widely available and had massive campaigns to make sure that every single person with HIV had access to the treatment they deserved. And we saw corresponding rapid decreases in viral loads and death related to AIDS. And so I think that's our collective goal and mission as a network, is to try and promote that kind of broad social change and healthcare change that led us to get in front of the AIDS epidemic. And there we can do it. There's my 7-year-old, Rosie the Riveter. So let's get into questions and answers. And please, you have the text box for asking questions. We have a few questions that have already come in that I can start with.
Yep, and in order to link your phone presence with your online presence, you want to make sure everyone on the line takes a moment to follow these dial-in instructions. So you're going to click on the phone icon with the question mark at the bottom of the participants panel to request to dial in. You see that red circle on the screen here in Figure 1. Choose the I will call in option from the pop-up dialog, and then you'll use the 3-step process in order to join the teleconference. So please take a second to make sure that you can dial into the line so that we can have some conversation around some of the work that you all are doing locally as it relates to these strategies to reduce opioid demand. And while you're taking a moment to call in, we'll have a second for Matt to address some of the questions that have come in, both for him and some of the other presenters. I know we've seen a few come in. So Matt, if you want to address some of those pieces, and then everyone, please, as he is covering those, do take the time to dial into the line.
Great. There was a question that came in regarding methadone that I can't read currently. Do you see that one? And this is a question that I'm going to turf to Brian. If you could answer question regarding, here's the question.
Yeah, so Brian, someone wrote in that while they recognize the importance of buprenorphine treatment, oftentimes the methadone option is diminished when in fact infrastructure for such programs can really help people who otherwise might struggle. So can you kind of take a time to kind of address that particular piece and how we might want to consider methadone here?
Absolutely. So, no, can you hear me okay? All right, cool. So Methadone is actually a perfectly validated and life-saving option for a whole number of patients. I think that of the 45 or so opiate treatment programs in LA, we do have and are able to link people to methadone treatment through the 24/7 phone line and the service and bed availability tool that I had sort of mentioned, where people can identify an opiate treatment program in their community. One of the other initiatives that I think is really relevant to methadone is our county, as you know, as Dr. Kahn mentioned with Bright Heart, has been funded through the California Hub and Spoke program to provide we have 2 opiate treatment programs which have been funded to provide technical assistance to our community health centers. And part of the idea is that, in an ideal world, each of our community health centers will have a linkage to a local methadone program where they might be able to refer a patient who would be in need of assistance beyond optimal medication management with buprenorphine. So there's people that really do need to be on a full agonist, and methadone can be a great option for those people. Buprenorphine is less federally regulated in terms of needing to be dispensed out of a federally licensed OTP. But I think it's definitely important that any community health center that is going to, identify and treat people with opioid use disorder be able to identify and link people to the opiate treatment programs in their communities if a patient would be in need of that kind of structure and support.
Thank you. One of the observations that came through was that the polls only offered one answer. So for the next time, we'll make sure that you can offer more than one answer. Some wrote in, including, is it Lisa from Lake County? That in that community, stigma, the barriers to MAT include stigma in the community, resistance by providers, too few waiver providers, and lack of knowledge of treatment options. So acknowledging the sort of multidimensional nature of the barriers. Those will be, and that's sort of the intent of this, is to sort of identify what those barriers are, describe that there are actually strategies that can be specifically implemented to address each of those, and we'll get into those on future webinars and coaching sessions with the coalitions in phase 2 of this, which would start in July. Another question is, this is a question for David, does Bright Heart Health take Medi-Cal patients, and if not, when will they start taking Medi-Cal patients?
David, do we have you on the line?
Oh, hello, can you hear me now?
Yes.
Yep.
Okay. Yeah, so Bright Heart Health accepts, we're a fee-for-service Medi-Cal provider, meaning that we can work with anybody who has Medi-Cal. And being fee-for-service is different from drug Medi-Cal by the county, meaning that we can take anyone who has Medi-Cal and we bill the state so it doesn't come out of the county budget for anything that we do. And yes, we can take them right now. We have Medi-Cal patients already.
Great. Thank you.
Should we jump to the line?
Yeah.
Okay, so we're now going to jump to the line. We're going to start with you, Corey Brown in Shasta. So we're unmuting you now. Corey, are you there? You might be muted on your side.
And this is a open mic popcorn session?
Yeah, and Corey, are you there? Okay, we'll go to someone else. Let's go to Daniel Kim in San Joaquin. We have you unmuted, Daniel?
I didn't have a question.
Okay, so what we're going to do now is open up the line to just any reflections, ahas, things that were interesting, intriguing, just what you might be doing in your own county related to the topic. This is less of a sort of question section and more just reflecting on the content and the work that you're doing.
Well, thanks. Yeah, no, for our county, we are just getting started. We're one of the early coalitions getting organized. I think the information was great in terms of some of the options, and it's something that we'll be able to discuss in our upcoming coalition meeting.
Excellent. Great.
Can we jump back and forth between written questions? And all right, so there's a question that came in: how do we address the concerns that Suboxone can be diverted and abused? This is a question that's come up around. I mean, sometimes in our own community in Marin County, people see opioids that are used for treatment as actually being opioids of abuse as well, and it's a disincentive for some to support MAT. Brian, can you address this?
Yeah, absolutely. Can you hear me?
Yep.
All right, cool. So the sort of buprenorphine misuse and diversion question, I think, has two parts. One part is there is no question when you put a medication that has opioid agonistic qualities, and buprenorphine being a high affinity partial agonist has agonistic qualities, that there are some situations where people may use it or sell it or divert it for reasons other than prescribed. The literature on diverted buprenorphine is less that people are using buprenorphine, and I'll use a colloquial term here. I don't know of anybody that uses buprenorphine to, quote, get high. Because if you're going to want to really experience a full intoxication, heroin is much cheaper than buprenorphine. So most people that go and divert buprenorphine typically divert it to avoid withdrawal. And oftentimes when you look at community-based research of people that are diverting buprenorphine, it's not really so much to like go rush after intoxication, but people oftentimes want to give themselves a break from the cycle of, like, say, heroin or oxycodone or hydromorphone or whatever sort of full opioid of choice they might be using. They want to give themselves a break from that. And buprenorphine can be really helpful for that purpose, even if it's not prescribed in sort of an appropriate set and setting. And so one of the concerns is, you know, is there a big risk of buprenorphine being out in the community? And I would say, well, the biggest risk is that there'll be people out there using it to avoid getting sick, but its safety profile is really much more advantageous to as compared with full opioids. And from all that I can see, diverted buprenorphine, if anything, might be actually partially protective against overdose rather than necessarily go and increase rates of overdose. So the public health consequences of diversion, in my mind, are more so that it keeps people using rather than necessarily that, you know, it's going to increase the risk of opioid-related morbidity and mortality. But the other piece that I sort of alluded to up front is that buprenorphine, you know, there's things that prescribers can do to try to mitigate the risk of buprenorphine diversion, and that includes things like making sure you're checking urines of the patients coming in and making sure the urines are positive for buprenorphine, because if you're prescribing to somebody and their urine is negative for buprenorphine, that implies or strongly suggests that they're not taking it. One of the other things you can do is to try to use the minimum effective dose. So not everybody needs to be on 24 milligrams of buprenorphine. And anybody, just as I myself, a buprenorphine prescriber, anybody over 16, one of the things that we explore is, you know, what are the reasons that you need to be on, you know, over 16 milligrams? And there may be valid ones, but I do so sort of cautiously and not necessarily routinely for every single patient. And the last thing is, you know, limiting the duration of prescription. You know, so I don't write for 90-day supplies of buprenorphine. The longest I would write for is 30 days, and even then, those are for patients that I really know well, who've demonstrated a history of sort of following up in clinic. And oftentimes, initially, when I'm stabilizing somebody on buprenorphine and really getting to know them, I'm doing, you know, a few days at a time, say 3 or 4 day duration prescriptions that do help then limit the amount of buprenorphine that's just out in the world. So to recap, keeping the dose you know, to as low as is effective. So I don't artificially keep the dose low, but I don't necessarily ramp everybody up super quickly for long duration scripts. I keep the scripts as, you know, sort of as low duration as appropriate. I'm always checking urine toxicology every time I'm writing a prescription, just to verify that the person is taking the medicine that I'm writing. And if I really want to get tricky, I'd get a norbuprenorphine level to make sure that they're not dipping buprenorphine, you know, pills or strips into the urine, but are actually, you know, urinating buprenorphine that they've been taking. And then I also practice acceptance, that I understand that there may be community diversion. I try to create relationships with my patients where they can tell me if they're diverting it. And if they are, then I encourage them to bring the person that they might be diverting it to into treatment. So those are all ways that I sort of think about managing diversion. But at some level, when you're offering buprenorphine, you accept some level of community diversion. And I think the benefits that our patients get from buprenorphine are worth the potential risks of diverted buprenorphine in our communities.
Thank you, Brian. I like practicing acceptance. Many of us, working in coalition leadership are in a position of kind of local advocacy for, getting partners engaged in some of these strategies. And just to recap, because I think we've all heard that argument that we're just replacing one addiction with another. It sounds to me like, one sort of talking point there might be that while it is possible to abuse buprenorphine, someone who's abusing buprenorphine is abusing opioids, and it is the safest of the options for someone who's going to be abusing opioids. Is that a fair statement?
I think it is. It's way safer than a full agonist. Absolutely.
That's right. So in that sense, it's a harm reduction philosophy towards this question.
And I like what you said about engaging your coalition, that we have this conversation at our, in front of the DA and in front of the coroner, in front of, the sheriff and our county partners that would be potentially faced with people who are diverting buprenorphine, just to provide some education on the context for that. And that really, if somebody is diverting buprenorphine, in fact, they might be actually closer to accessing treatment because now they've tried it, and if they really like it, then, well, maybe they should go get it prescribed in the context of a treatment program.
Great, thank you.
And David here, just a quick comment. So Michelle Lockwall out of Kentucky did a lot of research on this particular question. And if you hear about significant buprenorphine diversion, that's usually an indication that there's not enough treatment access, number one. And for somebody who's taken non-prescribed buprenorphine, it's really fascinating because it increases their likelihood of entering treatment, as both you and Brian said.
Great. So I have another, should I go to the written question?
Sure.
Yeah. Okay. So we have a question from Casey Grover in Monterey. Casey's going upstream. For many years, it's been the elephant in the room that the U.S. is the world's largest market for drug demand. We as a nation use and want more drugs than any other country. Do we know where this came from and how to decrease U.S. demand? That's an excellent question, and I think one of the strategies, that we acknowledged in this presentation and need to expand upon is the dialogue, the sort of social dialogue around preventing addiction in the first place. The fact is that the United States uses about 80% of the world's opioids. It's about 5% of the world's population. The influence of the pharmaceutical industry on the way we practice medicine and the way we as a community think is really obviously clear, especially in the direct-to-consumer marketing. We're one of 2 nations in the world that has direct-to-consumer marketing on television and other public outlets. I would suggest that that's changing. I mean, the recent opioid litigation suits where pharmaceutical industry is being held up, like tobacco was being held up before, might be the beginning of, a changing conversation. Are there, Casey, if you're on the line, do you have any other comments to that or suggestions for how we might address that issue?
I mean, I don't know if my voice is coming through. Am I on the line?
Yeah, we hear you.
Okay.
It is.
So, it goes beyond opioids. You look at methamphetamine, you look at cocaine. I mean, the U.S. is the world's drug market. Afghanistan, 30% of their gross domestic product as a country is opium. And where does that go? Western Europe and predominantly the United States. You look at, the interconnected relationship between the United States and Mexico, and it's Mexican drug cartels becoming transnational crime organizations trafficking drugs into the U.S. I mean, just as much as there is an opioid overdose death epidemic in the United States, there's an epidemic of drug cartel-related murders in Mexico, which is actually of a similar magnitude as far as the number of deaths. You know, so kind of the joke I always make is, we'll win the war on drugs when American and Mexican farmers make more money growing tomatoes than they do opium poppy because there's no demand. And similarly, looking at young people in schools, you know, they see drugs as a way to quickly make money because there's so much demand. And it really comes down to this inherent human need to get high and altered. And I keep thinking about this. I'm trying to figure out what makes people in, you know, Nigeria different than the United States. Maybe it's just money. Maybe it's the fact that we have a more robust middle class. But I feel like we cannot address this problem until we try to understand how Americans just want to get high, which drives this whole process and drives gang violence and makes this process so complicated. Now, maybe this is a question more for Dr. Khan with a background in psychiatry. You know, certainly untreated mental illness is a major part of it. But even then, I mean, you look at national statistics, and we treat about approximately 70% of people in America with major depression, as opposed to only 18% of people with addiction. So it's so multifactorial. I just kind of put it out to the group of kind of what's something we could focus on that, you know, when we look at high school juniors that are anxious, they want to engage in healthful behaviors rather than popping Xanax or Vicodin.
Thank you, Casey. That's obviously a super foundational question you're raising, and I think we want to continue to carry that thread into the rest of our conversations moving forward, as you know, as coalitions advancing this dialogue in the state. The communities that care. I mentioned the upstream strategy of the communities that care effort through the CDC, where they're talking about social norms change and basically policy systems and environment and education and awareness that does seem to have actual decreases in the number of substances that are being used by young people who are part of communities that are engaging in those kinds of upstream interventions. So there is some promise there, and we'll have some future webinars where we're describing more specifically what those strategies actually are at the community level, which may be promising in addressing kind of what you're getting at. I think we need to move on to the individual. We want to reach out to the individual coalitions to make sure everyone has a chance to speak. We have about 7 minutes.
Yeah, so we'll do another one here. Why don't we bring Jean Cunnington from Mendocino? Jean, we have you unmuted. Hi, Jean, are you there? Okay, we don't have you there. Let's go to Mary Ellinger from Tuolumne.
Hello, can you hear me?
Yeah, we can. Hi, welcome.
Hi. So,
hi.
Remind me of what we're talking about. The question.
So it's any reactions to the content, ways that it applies to work that you're doing, ahas, new ideas, things that you might already be doing?
Yeah, we're actually, MAT is an area where we've done relatively well thanks to a lot of effort on the part of our hospital, which started up a clinic, and our tribal clinics, which are also providing MAT, and then some other doctors in the community. So we are very pleased by that, but it's the challenge is a lot of those physicians are also older and wanting to retire, and so one of our challenges is how to sustain the effort, you know. So that's where we are. But we've been talking with Aegis and exploring resources. So it's good to hear about some of the other resources out there. So we have other possibilities to examine. But so MIT, I feel pretty good about. We have many other issues that are more challenging for us. And
Tuolumne is obviously a rural area. you mentioned Aegis. We've heard from Brightheart. You know, I think that's something we're going to just, we'll put a placeholder on, which is future conversations about the opportunities for services like Aegis or Brightheart Health to meet the needs of rural areas in connecting people to treatment.
I was very pleased, your slides about the, you know, sort of think through the steps of how to make sure you have a process that works to get people referred and so on, and we've done a fair amount of work on that, but getting that word out to our providers in our community in a coherent way, we need to work on that, you know. And one of the things that came up in a meeting we just had the other day was having a referral number, or, you know, we don't have that at this moment. I mean, there are people doing it, but we don't have a place to call one number, you know, that's publicized. So that's something we would like to see happen.
Okay. Thank you.
Great, thank you. And we'll do one more here. Patty Hoyt from Contra Costa.
You know, hi there, I'm probably kind of the wrong one. We are more of a community-based prevention coalition, and what our role in this kind of stuff is going to be is in supporting some of the other coalitions that are actually in there doing the work with providers and that kind of stuff. So.
Great. Well, we may need your help on some of those questions that were raised around upstream strategies and culture change that Casey raised and came up earlier.
Exactly. That's kind of our wheelhouse there.
That's your superpower. All right.
Well, we're working on it.
We may be calling on you for the webinar on that topic.
Well, all right.
Great. So we are going to wrap up now the presentation. Thank you for calling in, for that dialogue. And, you know, as Matt said, we're going to be having future sessions where we take a deeper dive and really kind of have some more in-depth discussion with subject matter experts, and for you all to exchange ideas and problem solve with one another around these particular strategies, whether it be upstream prevention, really kind of the facets around MAT delivery, stigma, all those different pieces. So please do look forward to that in the later phase of the program, now that we've provided this high-level overview for you all. We will be posting a recording of this session on our website, and it also will be available in the program newsletter that comes out every week. And we will be having the third webinar in this Boots on the Ground series on June 5th. So we've covered strategies for reducing supply, reducing demand, and then our last one will be on preventing overdoses. So please do register for that. The link to register is in that weekly program newsletter. And on June 12th, we also have a core webinar in our strategic communications series on tactics, tools, and timing, and really looking at developing strategic communication plans for your coalition. A lot of that does really draw on some of the themes today in terms of how you can shape your strategies for communicating to providers and other partners within your coalition and community around these efforts to reduce opioid demand. So please do sign up for that core webinar as well. As always, if you'd like to reach out to us, you can certainly contact me directly in the program manager for the California Opioid Safety Network. Here's my email and my number. And we will have Matt end on this slide with some artwork that he's provided. He drew himself, of course. This is an original painting.
Well, among the materials that people can have access to is some of the artwork that's been they're engaging as part of recovery, engaging people who are struggling with addiction to be creative. And I find many of these works inspiring, and this was one that came out of Newark.
Great. So thank you, Matt. Thank you, David. Thank you, Brian, and for everyone joining us today. And we will see you next time. Have a great afternoon.